today's topic of webinar, and we are utilizing this time of lockout. The topic is benign biliary stricture. With my experience of last 15 years in intervention radiology, I generally consider that people say that PTVD, transhepatic biliary drainage, is the very basic procedure, and it is very easy to do. Frankly telling you, if you are a good intervention radiologists who are really treating very nicely the benign biliary stricture, these are the, I personally feel, all you talk about tips or whatever the procedure, I still feel the management of benign biliary stricture is the toughest procedure of the whole of the intervention radiology. And why I'm saying so, because you have to understand the basic pathophysiology and what's the best way to treat these patients. You have to understand the biliary strictures are bad disease to treat, and if you don't treat it properly, ultimately these patients will become like a biliary cripple who will keep these problems recurring many times. So I'll cover my topic. So I'll not tell you the procedure, how to do it. I know that most of you know how to balloon dilate the biliary strictures. I'll tell you the basic pathophysiology of benign biliary stricture and what we see. Our experiences with these biliary stricture are far less as compared to our gastroenterologist, endoscopist, right? Because they do a lot of ERCP. In any of the center, there is no place where the biliary procedures percutaneously are more common as compared to the ERCP. So we have to take a lessons from them, and let's see what their literature says, and also our the gastrosurgeons colleague, the hepatosurgeons who do the surgery of these, right? So I'll start with the basic to understand the basic pathophysiology. So the benign strictures are most commonly the post-operative the biliary injuries, that is post-cholecystectomy. That is the most common cause. Besides that, there are dominant biliary strictures in primary sclerosing cholangitis, and now as the liver transplant is done very common in India also, the biliary strictures coming after that, the number of cases of benign biliary strictures have drastically increased in last 10 years. And also the common duct strictures due to the chronic pancreatitis, that they are in the lower end of the bile duct. So besides that, there are many other causes. Just to enumerate the few of the names: ischemic, post-sphincterotomy, radiotherapy, portal biliopathy, IgG4 involvement of the bile ducts, autoimmune. There are many causes, right? So I will take the few of the causes and will explain you what is the appearance. This is a very busy slide. Just to I'll read it for you for a few of the important points. That the most common, as I told you, the idiopathic, the iatrogenic, the biliary stricture post cholecystectomy, and they can involve anywhere from the mid proximal CBD, and they can ascend up to the stricture and then reaching up very high level into the intrahepatic part. And why it happens, I will come to it. Chronic pancreatitis, usually lower end. Primary sclerosing cholangitis, you know the beaded appearance, and it involves the intrahepatic bile ducts. IgG4 disease, this is most commonly the distal common bile duct, but again it can increase, it can ascend upwards and can even mimic like primary sclerosing cholangitis. Similarly, the pattern of sclerosing cholangitis is seen in HIV cholangiopathy, chemotherapy-induced sclerosing cholangitis. The Mireille syndrome, you know, the neck of the gallbladder or the cystiduct stone causes biliary dilatation. The portal biliopathy, because of portal cavernoma, these high pressure portal collaterals compress the bile ducts, which leads to the biliary dilatation. So this incidence of bile duct injury after at the time of when the open cholecystectomy was common, it was 0.1 to 0.2%. But we have to understand, lap cholecystectomy, of course, it's comfortable to the patient, but the number of these patients with benign strictures have increased as compared to the open cholecystectomy, that has raised up to 0.4 to 0.6%. And why this happens? This is basically because of the anatomical variation in the bile duct, and when the gallbladder is inflamed, it's not easy to do the surgery, and excessive use of electrocautery, there are bile duct injuries. So let's see some of the classification of bile duct injury and what we get to know from these classification. The most common classification of the bile duct injury is Bismuth classification. You must have must be knowing about it. You know it in the, it is also used in the similar classification, type of classification used in the malignant stricture. Similarly, the benign classification of bile duct stricture is also there. Besides that, there is a Starsberg classification. Starsberg classification, basically it also includes the acute injuries with the bile leak and the type E of, it is A, B, C, D, E, Starsberg classification, and the type E is almost similar to the Bismuth classification. So I'll come to the Bismuth classification. So it basically, why it is important to prognosticate, to plan the surgery, to plan the intervention, you have to define a classification. The type 1 is if the narrowing is beyond the 2 centimeters of the common hepatic duct from the confluence. If it is more than 2 centimeter, it is type 1. Less than 2 centimeter, it is type 2. It is reaching up to the confluence, but still the left and right hepatic ducts are meeting. It is type 3. Type 4, it has ascended into the intrahepatic part, into the right or left hepatic duct. And type 5 is a specific type of bile duct injury because of aberrant anatomy. The right posterior duct is got injured, and it gets separated from the main biliary system. Okay, so if we see that Starsberg classification, so it tells about the where in the acute injuries immediately after iatrogenic injury, where the injury is. So basically it includes where the injury has occurred. The type A is the bile ducts are in continuity, but there is a in the gallbladder fossa or some peripheral ducts got injured along with the Type 2 is there is a sectoral duct injury. Type B is sectoral duct, means a particular duct gets separated from the main biliary system and it leads to the continuous leak from it. Type 3 is it gets separated and it's get dilated. Type B is it's get dilated. Type 3 C is when it keeps on oozing the bile from a separated sectoral duct. And the type D is in the extrahepatic ducts. Type E is basically when it is associated with the strictures also. So type A to D is the acute injuries. Type E is the same sort of the Bismuth classification what we have seen. So basically still I would say the most important classification to remember is Bismuth classification. And another classification has come up, Hanover classification. They have basically included both the classification along with have addressed the vascular injuries. So I think nothing more than that. They have taken the importance of the vascular injury. So I will tell you why they have taken it into consideration, because a very important cause of these benign biliary stricture is associated arterial injury to the biliary system, and the incidence is very high, ranging from 12 to 39% of the patient who have bile duct stricture have associated arterial injury. And there is an article in which they have done the all biliary duct injury cases. They have done the angiography, and they have seen that there is some sort of angiographic abnormality in the form of injury seen in 47% of cases. And the right hepatic artery, of course, because it is close to the cholecystic duct, that is the most common site of injury, or as well as the replaced right hepatic artery. So injuries can be seen as an occlusion. We know that we see the post cholecystic pseudoaneurysm also, or there is complete disruption. So there is no definite recommendation that if a surgeon sees on CT or angiography, we see there is a vascular injury and surgeon goes for a reconstructive. It's not like that. There is no recommendation. But we know that if there is an arterial injury, it means the bile duct vascular supply is compromised, and we see that these patients have a tendency to early development if they undergo hepatococcygeostomy. Okay, so if there is associated arterial injury also, there is chances that the hepatococcygeostomy which is done in these patients, they tend to develop more chances of delayed stricture. So we have to understand that the best treatment, okay, I'll come it for the surgical part later. So then what are the consequences of these biliary strictures? Ultimately, if there is a long standing bile duct stricture, slowly there is development of secondary biliary fibrosis, and biliary obstruction is the most common cause of this secondary biliary fibrosis, and can they further lead to portal hypertension. So ultimately what is happening, long term presence of biliary obstruction is ultimately leading to fibrosis, cirrhosis of the patients, and ultimately further leading to the portal hypertension. That's why you see that because of presence of this biliary fibrosis and cirrhosis, in many of the patients there is very minimal dilatation of the bile duct. The patient is clinically symptomatic, but you won't see the bilirubin has not very much increased. Only you can see alkaline phosphatase, that is the value is sometimes 3 times or so, and if there is associated cholangitis, the SGOT, SGPT is high. But many of the time you'll see the bilirubin is normal, that is less than 1, and we consider that there is no obstruction. It is not like that. The patient is having recurrent fever, cholangitis in a setting of previous bile duct injury. We consider that the patient is having biliary stricture in any form, either in the normal, means the nave bile ducts, or after the hepatococcygeostomy. And ultimately what happens, there is recurrent cholangitis, there is a tendency to form the portal vein thrombosis because of this recurrent cholangitis, and may lead to the portal cavernoma formation. This secondary biliary cirrhosis, the incidence is seen in 8 to 18% in cases of various series. So this is not the chances are less, but if it is prolonged obstruction and we have not relieved it, that it may ultimately lead to the biliary cirrhosis. So risk factors for development of portal hypertension, if there is, as I told you, long duration of obstruction, and when the cholecystectomy has been done, the injury is there, and that there is a long duration between the primary cholecystectomy and the hepatococcygeostomy. So again, the duration is long, the more chances the patient will develop the secondary biliary cirrhosis. And if there is a history of cholangitis, and I explained you what is the cause, and if there is recurrent attempts to repair these, then there is more vascular injury to the bile ducts, and patient ultimately end up in biliary cirrhosis. Now let's learn from what the endoscopic guys do with the benign biliary strictures, and try to get it from what we should do and how we manage it, what lessons we have to learn from them. So this is the basic anatomy, and they enter through the major duodenal papilla, enter into the common bile duct, and they treat the benign biliary stricture. So the difference between the benign biliary stricture and neoplastic stricture is that they are difficult to cannulate, they have a greater asymmetry, the angulation is different, and there is a lot of fibrous tissue around these biliary strictures. That's why they are not easy to cannulate, to cross the strictures. And what they do sometimes, I have seen it in our hospital also, what they do is, if they are doing the ERCP in the distal bile duct, they inflate a balloon and withdraw it, so everything moves, and the traction improves the alignment of the separated bile ducts or the stricture, and then this straightness ultimately facilitate in passing the guide wire. I have used in one case to do it with inflating a 6 mm balloon, then pulling the whole assembly and try to cross the stricture with the wire that has gone through the balloon, and it has helped. As well as we know, the guide wire, you can make the shape of the guide wire according to the anatomy, and but still the most common workhorse for the gastroenterologist and us also, it is the Thermo 035 wire. In some cases the 0.025 wire is also helpful. So again, these are the wires which the endoscopists use, but factually there's every company has its sort of hydrophilic wire, but ultimately practically everyone use the Thermo 035 wire, either a J tip or a straight tip most commonly. Now coming to the balloon dilatation, what they do is, so they dilate it with a balloon, or they just place a sheet and tapered dilatation they also do, but most commonly the balloon dilatation is done. The 4 to 12 millimeter balloon they use, and we also use the same. The concept is, then we use the balloon 1 to 2 millimeter more than the diameter of the distal bile duct. Okay, so whatever the diameter of the distal bile duct, use 1 to 2 millimeter more. In the post-transplant cases, there is you have seen those who do the post-transplant cases, there is a mismatch between the donor and the recipient bile duct diameter. So you use the 1 millimeter or exactly the same size, whichever is smaller. Means if the recipient bile duct is the recipient bile duct is smaller or the donor is smaller, whichever is small, you use the same balloon. You should not oversize very significantly. And also it depends on at what stage you are doing the early post-operative. Some are hesitant to using the balloon, but 1 month post-transplant is good enough to use the balloon, it's my belief. And most of the time, how much balloon they keep inflated? 30 to 60 seconds, what we usually do, or until the stricture base is fractured before they deflate the balloon. The most important part, now coming to what we have learned from them, that ballooning is okay. We also use 30 to 60 minutes, few use 2 minutes. There's no definite protocol or the approach that will say that this much dilatation is very effective, or there's no definite approach. But this particular part you have to learn from the gastroenterologist, that's stenting. So if we do just the balloon dilatation and come out, the stricture rate is approximately 47%. Means 50% of patients will come back with the stricture. So what they do is place the biliary stent. And what is the concept of biliary stent? Is to maintain the stricture patency, and they keep it for a long time so that the bile duct which is surrounding it gets remodeled. And what they do is, actually they try to place multiple plastic stents. And how much time they keep it placed? Up to 9 months to 1 year, right? So 2 things we have learned, that multiple stents, plastic stents are better, and they keep it for 1 year, right? And every 3 months they exchange it. That is the recommended approach for majority of the bile discharge. So same approach we should also consider, that we require multiple transhepatic internal and external drains, and we have to keep it for 1 year and give the body time to remodel the stricture. I'll again emphasize at this point when we come to the percutaneous approach. So multiple stents, what is if the multiple stents are going, so where the stricture is, even the plastic stents gets occluded, there is space between the 2 stents, so the bile keeps on flowing through these spaces, which is called the Wick effect. Okay, so this is again helpful in our cases also. If we are placing 2 internal external drain across the stricture, of course there are chances that these internal external drains get blocked, but still the patient doesn't develop the cholangitis, because the space between the 2 internal external drains, the bile keep on flowing. Okay, so their data is very robust, more than 10 years. I will not go into detail, but you understand that the results are very much, they have experience of more than 10 years results. Now coming to the, see the, why we don't place an uncovered stent in these biliary strictures. So this is a systematic review of about more than 1,000 patients. They have collected their data from the, this is the the endoscopist data, and they have said that they balloon dilated it and try to place one or more plastic stents, and stent exchange is done every 3 months, and increasing number of plastic stents which progressively dilate a stricture or the papilla. So major disadvantages of this protocol is that we require multiple procedure every 3 months, and there are chances of that stents gets blocked. Uncovered stent in the benign biliary stricture should not be used, should avoided always. Why? Because ultimately they give a good short-term efficacy, but ultimately because of epithelial hyperplasia around the bile ducts, they develop the ingrowth and causes blockage of these metallic stents, and the problem become even worsened. Then what to do after the blockage of these? When there is an intermedial hyperplasia, they require the removal of the sludge, and it becomes very difficult. And because it gets embedded in the, there is epithelial lining there, so surgically the removal is also becomes very difficult. So I'll just come to that. So what they have shown is the overall efficacy of multiple plastic stents is far better than single plastic stent, and clinical success you can see. And short term, okay, the results are good with the uncovered stent, but ultimately complication in the long term is far more. Now if the stricture is below the confluence, there is a role of covered biliary stents, because it maintains a radial force and allow the bile duct to remodel, and you can keep it for about 9 months, and then you can remove it without so the requirement of the procedure, multiple procedures, decreases with the use of. But that is only feasible in where you can place it precisely that it is below the confluence, or you have when you have crossed to one lobar duct, the other there is a possibility of either external or internal external percutaneous drainage of the other liver part. So I'll just basically this is just to suggest that they have very robust data, and they have results for more than 10 years, and this is the crux, that multiple stents is required and one year protocol is required. Now coming to the surgical management of these. So how the surgery is planned in these procedures. If the cholecystectomy is done by a very good liver surgeon who knows how to do the hepatojejunostomy, he has experience, then the best treatment is, if the surgeon finds the leak of the bile duct, there is injury of bile duct, he should do it on table, make it an open case, and do the hepatojejunostomy of the table. If there is surgeon has done the surgery, found the bile leak, but he knows that he doesn't know how to. What they do is, if he is a intelligent surgeon, he will place a drain close to the site of injury and will immediately send the patient to a higher center, right? So that if there is leak, keep on going, and it will not accumulate in the abdomen. And if it is the patient come after 6 days of the injury, usually the surgeon wait till 4 weeks or 6 weeks or maybe 12 weeks. Why? Because they want that the edema and the inflammation around the ductal system decreases, the biliary fistula has formed, the bile is not accumulating in the abdomen, and so that they can do a surgery later. So early repair, there is a high risk of bile leak and stricture formation, and with high mortality and morbidity if the surgeons do it in early period when there's a lot of inflammation and edema. One thing I want to again emphasize, that let's say you must be getting the patient who have the post cholecystectomy, the bile leak, and abdomen is full of bile. It's very easy to put the drain in the right iliac fossa or in the pelvis, but the best way to treat these patients is, of course, you can put a drain in the, but definitely a drain is required close to the bile leak. That is, you place it through the Morrison's pouch so that your catheter reaches close to the site of leak, because if you place it just in the pelvis, ultimately it will seep from the site leak, will go along the abdomen and will drain from the pelvic side. So that's not a good approach. You should place in either there should be a drain close to the site of bile leak. Surgical reconstruction, what they do is, so basically best treatment of benign biliary stricture is no doubt the hepatocholecystectomy. The endoscopic or percutaneous methods are not a good option unless until there is stenosis and endoscopist can easily detect it. If it is somehow a complete cut off or something like that, you might be getting some cases that we are not able to see the proximal bile duct. What you do a PTPD, cross the wire and give us. Actually, if we are able to cross it and give it to the endoscopist, the result will not be good, and this type of patient require hepatocholecystectomy. Anyway, so coming to the hepatocholecystectomy part, so they make a roux limb so that there is tension-free anastomosis, there is mucosa to mucosa anastomosis, and a very good vascularized bile duct mucosa is anastomosed with the bile duct. So what they do is, they use it is the anastomosis is not usually end to end. They do it side to side. They make a transverse incision in the bile duct so that they get a horizontal oval sort of anastomosis, which will have a bigger diameter as compared to the end to end anastomosis, which is of less of caliber. Besides that, along with the hepatocholecystectomy, the partial resection, like if it is high extended going into the left hepatic duct, you connect it with the right hepatic duct and remove the left lobe, which maybe become a possible cause of recurrent cholangitis. So resection is performed in along with the biliary reconstruction and have shown a good long-term success rate. So long-term results, if you see if the recurrence of hepatocholecystectomy stricture after surgery, it usually occurs within 2 years. Why? Because most of the time it is associated with the vascular injury. The bile duct which I have anastomosis is not vascular, and that's why the recurrent strictures are coming. So even type 3 or type 4 lesions, it's not that surgery is not feasible, but yes, the recurrence rate and the complication rate becomes high. And redoing the hepatocholecystectomy is a difficult task for surgeons. They don't want to get it repeatedly done unless until they are forced to do it. That when we say that we can't do it or something like that. So try to understand that it's easy to say that we can't do this biliary process, but ultimately you have to understand surgeon is also not going to do a good job, and it is our responsibility to try these difficult cases and make these patients happy at least for a few years. I'm talking about few years. These patients become biliary cripples. So important factors and predictive of adverse outcome is type 3 and type 4 biliary strictures, means higher strictures, multiple attempts to repair has been done. There is end-to-end biliary stenosis and there is biliary sepsis. Now coming to our part. So I'll just summarize what is our data comes up, that there is stenosis, re-stenosis rate. I'm just directly coming to the results. The re-stenosis rate after we treat it, the 5 years, 10 years, 15 years, 20 years, 25 years data is there, and the chances are after first PTBD 0.5 to 0.49. So try to understand that even 5 years, 50% of these patients again come back with the same problem. Okay, so should not say that once I will treat you, you will ever be treated. There are chances that there and a significant number of chances that. So I usually tell that the 5-year patency rate is 50%. Frankly, I tell this type of result to my patients. Now, there are other problems associated with these strictures when we treat endovascularly the presence of intrahepatic stones. There is a actually separate topic just to say that the surgeons also put a hepatogenostomy access loop. When there is multiple intrahepatic stones, percutaneously removing the calculus is very difficult. So you have to enter into this rule loop, anchor it, and try to extract the balloons from the jejunal side rather than the PTBD side. I'll come to it later. I'll explain you. So because many important things, I have taken already a lot of time. So this is the rule loop jejunal axis that the surgeons form, and so anatomy is like that. So the bile duct is anastomosed. You can see in the first figure, the pencil diagram, that this is the rule loop, so that the intestinal contents doesn't go into this bile loop, and the chances of regurgitation, the cholangitis is not there. So I'll skip this. I've taken, yeah. So I'll try to cover the few interesting other topics beside this. So what's our protocol should be? See, if we do a case of bile duct injury with hepatogenostomy, let's say hepatogenostomy stricture is there, the confluence is patent, it's very easy to go from the right side or through the left side, cross the wire, balloon dilate it, and the stricture looks very good, and we are satisfied we have done the treatment, and we remove the internal external after 3 months. So we should also follow the gastroenterologist protocol, that multiple internal external drains are required to keep the hepatogenostomy dilated, as well as keep the time for 9 to 12 months, so that remodeling occurs during this period. Then the best, that will be the best scenario when you are offering a best treatment to the patient. So it's not you just put one single internal external. More the number of internal external drains, the better will be the results. And you have to keep it changing every 3 months till a year. So I'll just brief you in short about the few interesting parts that have there. You can say relatively newer developments. The percutaneous cholangioscopes are available. There is choledocoscopic high frequency needle knife electrotomy is available. So what they do, how it does, so basically it goes from the transhepatic route, you can see this cholangioscopy, you put a needle knife, and basically it's the laser cutting of the bile duct stricture, and it is dilated. So this is the appearance. They have used a needle knife and dilated it. So this is a new development. Also, you must have heard about the transhepatic cholangioscopy. So basically these are thin cholangioscope. The spyglass, you have heard it from your endoscopic colleagues. They use the spyglass. It is more or less similar, or you can say the same cholangioscope. You can use it, and it goes to even from the 9 French catheter. So it goes very easily you need not to dilate it very long. Usually, preferably, you do it in the second setting when the tract is mature, and it has a diagnostic role to see whether the stricture is benign or malignant. You can see the vascularity. You can take a cholangioscope guided biopsy also. So just to show that benign stricture, sometimes the cholangioscopy, you see this pinhole only in the cholangioscope, and you try to poke at that point, and you are able to cross the strictures. There is a therapeutic role also. The lithotripsy can also be used to basically macerate the larger balloons, and as I told you, to defining the stricture, to entering it, as well as the needle knife technique, means you puncture the bile duct exactly at the point of the target, and with the use of laser, you dilate it. So there are few case reports of using the steroids within the bile duct, but actually these are more or less experimental sort of. There is no data to suggest that these are useful. And also the transpercutaneously, there are also possibility of placement of retrievable fully covered metallic stents, same as the endoscopy is used. But again, you have to see that most of the strictures we get is either post hepatocytostomy or post transplant. These are the cases we usually get. So in cases where this hepatocytostomy has been done and you want to try a covered stent, so you will place it either from the, let's say you place it from the right, and the covered part is definitely going to cover the left hepatic duct, then you should have an access of left side PTPD. So the patient, that covered stent will not obstruct the left side hepatic duct and patient will not develop cholangitis. Yes, there is a, because the number of interventions decreases with the covered stent. And the results that are showing that biliary stenosis, the success rate is 83%, 62 to 83% with the 24 to 36 patient. So I'll skip this. So what's the conclusion is that a stent dwell time period of 1 year seems to be recommendable. We need multiple entries into the liver through the multiple PTPDs. That will be the best treatment for the patient. If you can't you should at least try to give the best treatment to the patient. So I'll skip few of it. Yeah, again, as I told you, the duration of catheters, the 12 months, the data is there that if you place it for long terms, the data is good. Now coming to a very important topic, the biliary manometry. That is very important. You see, what happens when you balloon dilate it? Many times you must have seen the contrast is very nicely passing into the across the stricture. But sometimes you see the contrast is not passing immediately after the dilatation. So that frankly doesn't mean that this is a failure. So the cholangiographic achievement of free flow of contrast sometimes it's not directly related that your balloon dilatation is unsuccessful. You place the multiple stents, wait for 9 to 12 months, the remodeling will occur, and you see the contrast is not passing on the cholangioscopy, but actually the patient symptoms and there is good clinical improvement. And so what's the best way if we are not getting very good clear cut that how effective is my treatment is, then the best to do is the biliary manometry. What's the concept is, you connect the bile duct, you place the catheters in the bile duct proximal to the stricture and slowly increase the saline flow within the bile duct. So if the passage is very clean, it will go into the jejunum and the pressure will not increase. But if increasing the flow from the saline, if you can see in this diagram, there is an infusion pump, there is a water manometer, the biliary catheter is going into the biliary duct. If the pressure will increase in the bile duct, ultimately the manometer will increase, the manometer will show high readings, and you can see that it's a very good method to see your treatment is effective, and it's a good time that we can remove the catheters. So there is a good data showing biliary manometry. The long-term experience also, they have also suggested that if someone is passing the biliary manometry, you can get it very easily. Just type the biliary manometry, you will see what is the injection rate, how much pressure is the baseline pressure, and how much it increases if it is ineffective. So this is the published data that I'll read it a few sentences for you. That this is a logical necessity because most anastomotic stricture are fibrotic in nature and elastic recoil after balloon dilatation is anticipated. Quantification of the degree of stenosis within a bile duct is difficult and questionable utility. Means just see the stenosis, your contrast is not passing, that doesn't mean that the system is completely obstructed. So the best way to deal it is with the manometry. And repeated balloon dilatation required. There is a very good article in JVI 2012 that, of course, we change the internal external drain every 3 months to prevent the clogging of the stent. But every time we should do the cholangiography and multiple, every time you do the balloon dilatation, No, it is not. They have done a study. They have divided two groups in which they have done only one single balloon dilatation in the first procedure and put the internal drains, and then change it every 3 months. In the second group, more than one balloon dilatation with every change they have done, and they have shown the results are nearly same. So basically additional balloon dilatation in the 3 months 6 months follow-up is actually not required. So the first setting balloon cholangioplasty is the most important. So there are biodegradable stents that are possibly come. I don't know. There are very less literature available on that. So basically the concept is that within the 3 months, they start disintegrating, so that it is just like you have heard about the coronary scaffold, means no stent is left. So you place it, that you can keep a access tube, and it slowly gets disintegrated, and the metal, there is no metallic thing left inside. So basically it is the polylactide acid PLLA stent, which is a bioabsorbable biliary wall stent. So there are this just a minute. So there is some data that they have used two magnets in the proximal and the distal bile ducts to straighten up the biliary stricture to help in the crossing the strictures. But I have never seen that. There is a few Japanese study that say that helps in crossing. So I'll end here because I have already taken 45 minutes approximately. So basically we try to learn from our gastroenterologist colleagues what treatment and should incorporate in our cases also. So I end with this talk. So any questions if they want to put, I'll be happy to answer that, and my panelist colleague also. So I think the first question is, what is the duration of balloon dilatation and how many times? So basically the 30 minutes, 60 seconds, 2 minutes, there are multiple studies are there saying separately this one is good. So ultimately the thing is, you should not keep it very long dilatation like 5 minutes or so, because ultimately if it is a long dilatation, ultimately it causes more of injury to the bile ducts. So single balloon dilatation and keeping it for about a minute or two, just that will be done, and you need not to dilate every time when you do the cholangioscopy in the cholangiography in the follow-up period. How feasible is endobiliary